testosterone for the newbie, testosterone for any of you men out there that really don't know about testosterone and steroids and you're new here, yet you're on testosterone, or again, you're interested in starting testosterone and you really don't know anything about it and you want to be as careful as you can be. So this is testosterone for men that are new to testosterone. You know, this is also for physicians that are great physicians, but they really don't specialize in testosterone and androgens like I do 24/7 as an internist for about 20 years now. I'm very respectful to other physicians about that. So number one, if you want to see a compendium online about every side effect and issue on testosterone, go to the channel here in the playlist, the 12 rules to live by on testosterone. I did that about a year ago and we broke down every single side effect. That was an online compendium just for men that are on testosterone. Again, this is really discreetly for testosterone replacement, not really steroids, but you could read into it that if you're on steroids and higher doses of testosterone, you're going to exacerbate each of the side effects, obviously. Kind of common sense. So, number one, when you're on testosterone, gentlemen, and your doctor is prescribing it to you, or you're taking it yourself, because I know a lot of men do in the world, let's talk about the route of administration. We have oral, we have pills, testosterone undecanoate. There's two different, if not two or three different types now that are out there in brand names in North America. It's interesting that they're coming into the marketplace because everyone's getting on testosterone and people don't want to just slap on the gel or inject. So the oral ones are going to be really, really important. So there's oral, there's going to be topical. That's the gel and the cream, been out there forever and ever and ever. There's trade name gels. There's tons of generic. You can go to compounding facilities that are very good and they can make you concentrated types of topical. I use it all the time for patients. Instead of using the trade name that's very expensive, you can just go to a compounding facility in North America or in Europe, anywhere in the world, Asia, anywhere in the world, Africa, and you could have a compounder make it for you concentrated and you just put it on your skin. Be careful with transmission to partners and children. Next is going to be pellets. Pellets are in the world, and again, they're not bad, but in my opinion, they're not optimal because when you put the pellet in, several pellets, beyond the fact they could extrude and they kind of can cause people to reject them, which is kind of interesting. Wonder how that was put in and how does that happen really, but it can happen. I think it's rare. There can be it can be painful at the site. There can be reactions at the site, but it's usually uncommon. The pellet problem is it's the pharmacokinetic. The pellet goes in, depending on how many pellets your doctor does, and the pellet, the peak to concentration and the testosterone levels are going to start to go up right away, and they're going to peak. You know, they're putting these pellets in every 2 months, and you know, and you're going to peak, and it just doesn't. It's a gradual up and down, and you may feel good for a period of time. You see that when it hits a area in the area of the curve where it's peaking, and you feel good. Maybe it goes too much, you feel bad, right? Or maybe you hit it and then you feel great, and then it's on the down low. It's going down. The kinetics, right? Everything goes up and down, guys. It's pharmacokinetics. Half-life and all this kind of stuff, man per man. That's why when I do this stuff, I have to look at men independently as a doctor, and you have to really understand nadir dosing, and you have to really understand peaks and troughs and man per man. So when you look at a pellet, it's notorious that men will say, there's a period where I felt good, but then I lost it. Now they're waiting to get the next pellet, and they could wait maybe a month or more. So I don't like pellets. But again, if you're using a pellet and you feel great, that's great. Don't change it. Nasal. There's nasal testosterone. If you're watching this video, I'm sure you're concerned for your testosterone levels. In addition to testosterone, you want to check sexually binding globulin, estradiol, free androgen index, and potentially cortisol. That's where I want to talk about today's sponsor, Let's Get Checked. They're a worldwide leader in at-home test kits, so you can get a comprehensive look at your testosterone levels and other labs without even leaving your home. You can order a test kit that will be delivered to you in discreet packaging. Once your sample arrives in the laboratory, confidential results will be available from your secure online account within 2 to 5 business days. These results are reviewed by a clinician, and a member of the Let's Get Checked nursing team may call you to review your results. Let's Get Checked laboratories are CLIA approved and CAP accredited, which are the highest ranking levels of accreditation for labs. So if you want to test your hormone levels without having to leave your home, visit trylgc.com. There's nasal testosterone. I can't say trade names here. There's nasal testosterone gel. And it's, I believe, twice a day. You can see I don't prescribe it. And again, it goes right into the central nervous system. Guys feel great. Supposedly, it maintains men where they potentially don't get shut down and can maintain fertility. Wow! I should do a video on that itself. I'm not sure I really believe that, though. I'm not sure I believe that. But I think there is some data on it. And if you guys know about this, or you're expert physicians out there, or scientists, give some comments. And all you men that are experienced, give comments for all these other men that are newbies. Next is going to be intramuscular and sub-Q. Okay, old school, and that's what I use, 30 years, and that's what 90% of men in the world that are on testosterone, they are on intramuscular or subcutaneous taken doses. Now, the next thing is you want to do the lowest effective dose, gentlemen. Let's just kind of move forward now, assuming you're doing small injections. Don't do 200. If your doctor is giving you one injection of cypionate, enanthate, of Testosterone 250 every 2 weeks or a month, it's not proper. It's not proper, gentlemen. It is what it is. You may feel good on 1 mil every 2 weeks, but my Lord, that peak and trough, again, peaks and troughs. It's going to be way up and down. Be respectful to your doctors, but you may want to say, doctor, I want to microdose further. And you don't have to take 0.1, 0.15 milliliters every day or every other day. You could see my video on microdosing where I used a real man who does, because he just feels better with his acne, his estrogen, and he doesn't mind doing it. But gentlemen, this is going to be a lot of work. Being on testosterone is a lot of work. That's number one, and you're going to be on it for the rest of your life. It's my number one risk and my number one most important variable for a man to understand before you start testosterone. Are you really that bad? Do you really need it? These are for young men, right? So young men have to consider this. That's why I'm doing my part, guys. So again, microdosing is usually great. Most of my patients, including me, cypionate, 200 milligrams per mil, 0.5 milliliters, intramuscularly injected every 5 to 6 days. Some guys use 0.35 every 3 or 4 days. This is where you have to find the peak and the trough. And it's nadir dosing, nadir, N-A-D-I-R. It's a trough, and you want to look at it based on the half-life of the medicine, which is, again, in this case, cypionate or enanthate. They're basically identical when it comes to the pharmacology. I know there's differences, guys, but most men can't detect the differences. They're interchangeable. It's not Testosterone 250, it's not propionate. Certainly not testosterone undecanoate. That's the long-acting one. And again, that one, I really don't like either. It's kind of like the pellet. It goes up very, very long. In Europe, it's every 3 months. In America, it's dosed 750 milligrams intramuscularly, given in the glute only, because it's a big injection, every 6 weeks or 2 months. 2 months. And in Europe, it's given every season. So you have this ad where you have the guy in spring, and then he's in France, South France in the summer, and he's getting an injection. Then he's skiing in the Alps in the winter, and he's getting an injection. It's easy. Well, they don't always feel great, and it could be up and down. Again, this is testosterone undecanoate. Can't say trade names. There's multiple trade names. So that's route of administration and dose. Number one, gentlemen, that's going to be number one for you to really understand. I really hope that helps. Gentlemen, give comments. Next, ancillary medications. This is it. Guys start testosterone. It's notorious, from anti-aging facilities to regular doctors to men in the streets. Here we are. They add other drugs to these, like it's mandatory. There's no data for this. Let's roll the sleeves up, guys. Aromatase inhibitors built into the injection. If a doctor is giving you aromatase inhibitor, anastrozole, or other aromatase inhibitors, they're for breast cancer. We have to be careful. I'm not saying you can't use them. I'm just saying it's not McDonald's cookie cutter. If a doctor is putting that in the mix, consider getting away from that facility. I've seen it all the time. You can't cookie cut it. You can't give every man a built-in testosterone cypionate or enanthate oil mix from a compounding facility, and then they're adding in an AI. That's cringy and embarrassing to me. Unless if you want to do it and you feel great and you don't mind the side effects, some of them potentially dangerous for the heart, and you feel great, go for it. Go. It's easy. I mean, are you really that lazy? I mean, just separate them. So aromatase inhibitors can be used. However, when you're new to testosterone, I've been doing this for 20 years as a clinician. In my opinion, you start just testosterone, and then you see how that goes, and then you manipulate the testosterone route of administration. If it's a topical, if it's a pill, if it's the oral, if it's a pellet, the nasal, if it's intramuscular, you manipulate the dose and the concentration to get to where you like. If it's estrogenic side effects, if you have gyno, or you're moody, or you're up and down, and your sex is good and bad, so in my opinion, it's a man-to-man. Give it 6 weeks to 2 months after you start, especially on the injections, and look at the nadir dose. See that have your doctor order ultra-sensitive estradiol, not a total estrogen. It's contaminated. It's useless. If they do the total estrogen, it's erroneous. It's a medical error. It's just not going to be accurate. It can be accurate, but it in many circumstances it's not. Ultra-sensitive estradiol if you want to see the estrogen. And again, if you want to manage the estrogen, take less testosterone or microdose. I really hope this helps you guys. And you have to forgive me for getting emotional, but I do it for my day job. And when I see it's so simple, why is everyone taking all these extra drugs? And then you guys come to me as a doctor, and I just kind of hit a reset button and just kind of restart over and just make things simple, and it works out to be great. And of course, I look at the heart and the red blood cells, and I'm going to cover that in the end for you guys here. So if a doctor gives you gonadorelin, don't use it. I'm not saying it can't work. We don't know about it. Gonadorelin came out from the anti-aging facilities during the pandemic, and probably before, when human chorionic gonadotropin was shut down from the FDA, and they couldn't get it. And I'm not going into the politics. They've restricted HCG to only licensed providers that are more specific. They took it away from anti-aging facilities using compounding pharmacies. It is what it is. And when that happened, you saw gonadorelin come into the market. Give comments, guys. This is fascinating. Gonadorelin could work. It's above it's a GnRH analog. I don't even know about this drug because I'm humble that I don't know everything, but it seems like it could be good and it could work. But if you see the comments and you just see the data on it, it's potentially it's not going to work, and it could make you worse, and it could just monkey up and make the regimen of testosterone either dysfunctional, or it could hurt your chances of fertility, where it may you think it's going to maintain your fertility and your Leydig and Sertoli cells, but it may for a while, but it may be worse. We have no idea. Where's the data? There's no data using it it prospectively with testosterone. So 8CG, that's a start to move into something, a medication that can be used, human chorionic gonadotropin. I have a lot of videos on this. This is a drug, this is an ancillary medicine that can be used. It's an alpha, it's a LH, alpha, it's an analog of LH coming from the brain. It's gonadotropin. It comes out of your brain, LH and FSH, and it does work on the testicles. However, again, there's no prospective data long-term co-administered with testosterone. However, there are some very good doctors. Dr. Lipschultz has done work on this. Other expert, he's a fertility urology doctor in Texas, and he's an outstanding doctor, and he's published a lot of research papers on steroid users with fertility. You could look at Dr. Lipschultz, steroids, fertility, 8CG, not to mention Clomid. So when you use 8CG with testosterone, again, if you're new, I don't recommend just starting it right off the bat. However, if there's any medication that you may want to start right off the bat with testosterone, it's small doses of human chorionic gonadotropin. I agree. I give it an option to my patients. But I've been on testosterone 30 years. I've been off it for decades. It's a lot of injections. It can increase estrogen. It can shut down your testicles from paradoxically actually worsening the ability to have your testicles come back if you come off, or if you want to come off and regain fertility. I use it only for fertility, exclusively with Clomid, depending on the man. Not Clomid by itself, but 8CG by itself when a man wants to get fertile. This is kind of advanced newbie stuff. You want to come off and then just go right on 8CG. Some doctors say just come off. And then you're going to come off and you're going to feel bad. And you're going to go right back to feeling poorly, and you could have erectile dysfunction, so you can't even have sex. So how are you going to be fertile? It doesn't make sense. And another caveat is there's doctors in the world, this is, again, they're not bad doctors. They commonly will stop testosterone every 6 months for a month or two to let you clean out and let your receptors come back and let your testicles come back. This is insane to me. There's no data for that. And so many men have come to me because they're like, Doc, do I really have to come off? I'm feeling horrible now. However, for a month or two, and then what is it for? Why would you do it? Doctor, I don't understand why that's done. You're on testosterone. You're considering you're on it for life. There's no data to say that you're going to go off it every 6 months and it's going to bring your testosterone back. You had low T. You had low testosterone. That's why you're being treated. I don't get this. That's potentially dangerous for the man, because when you come off testosterone, the FDA has a warning for withdrawal, and you can go into a depression. And if you have depression and you're on testosterone, and indeed in part for your depression, and you feel better, and then the doctor is stopping it every 6 months to make your testicles come back to life, that's completely wrong. Where's the data to argue me? Serve it up. Be careful with that. Again, if you want to do that, go for it. Go for it. Does it work in the end to maintain fertility? It may. I mean, it's less. Your testicles are coming back, and your exposure to androgens from the hypothalamus pituitary gonadal axis, it's just going to be less. It's like doing less steroids. You have a chance of coming back. Your testicles, gentlemen, you're new. You have to understand your testicles are going to be shut down, even on testosterone. This trick of coming off every 6 months, is it going to work? There's no data to say it's going to work. It may work, but you're not going to feel good. You're going on testosterone for the reason to feel good. Now you're like, oh shit, next week I got to come off. My doc's pulling it off for a month. Beware. Last part, gentlemen, newbies on testosterone. Last part, ABCDs. Look at the videos. If you're on testosterone, you have to be aware of your heart and your prostate. Watch the videos I have on this. You could look at Dr. Nolan's interviews where we understand the cardiac disease on men. I like that the data is coming out from traditional physicians that there's no risk for your heart being on testosterone. I'm not sure why they're so confident about that, because 10 years ago, they said there could be risk, and there's no new data to really show us that it's truly that safe. So proceed cautiously. Lowest effective dose, hemoglobin A1C, glycemic index, check your labs. Get on the Anabolic Doc app. I'm here to help you guys with all this. I've enabled labs there, and you have access to me and my information on the Anabolic Doc app. B is blood pressure. Testosterone can increase blood pressure. Your blood pressure is increased. There's no way it's not going to affect stroke history potential in the future and or cardiac coronary disease or cardiomyopathies and LVH. If you have hypertension without testosterone, it causes all this. So if testosterone causes hypertension, I don't understand how it can be completely clear of any risks. Think about this. Work with good doctors. That's B, blood pressure. A, A1C, glucose, hemoglobin glycemic. B is blood pressure. C is cholesterol, cardiac disease. Get a calcium score. C, calcium score. Look at your coronary artery disease risk. It's not just Framingham. It's not just Framingham. We're beyond Framingham. Framingham is the risk assessment scores that doctors like me, primary care doctors, use to predict your risk for having a heart attack in the future. It's not perfect. D is deposition disease. Gentlemen, depending on who you are, what you take, what your medical issues are, sleep apnea, your genetics, your diet, other medicines, you are going to have to manage your red blood cells and your iron. This is my number one albatross that I deal with on my neck every day for my patients. Red blood cells go up, it's going to happen. Androgen-induced erythrocytosis is the process. It causes increase in red blood cells for every man to some degree. Not every man is polycythemic. You have to understand what polycythemia actually is. Not every man is going to have iron overload, but you have to look at your iron studies, and your doctor's probably not looking at your ferritin and your iron studies. These are videos. I have a playlist just for red blood cells. You really want to understand this, gentlemen. If you're new to testosterone, please digest this video piece by piece. Give comments. Guys that are veterans, please give comments to hear what's happened, because this platform is for men in the world for educational purposes. And please, if you want access to me, of course you can do consults. I'm booked out a few months and I'm humble for that. But you can get on the Anabolic Doc app and you can see all my medical information. I have private specific information that are pre-recorded videos just about this stuff, every piece. We have an H&P, we have a library of medical information you can look at and you can identify and index. And then most importantly, you can come to meetings with me live and ask me questions. That's it, gentlemen. Testosterone for the newbie. I really hope this helps men in the world. Thank you so much, gentlemen.